This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
I'll get our other panel members to come up on stage and I'll introduce them and then we'll start taking some questions. Thank you. I'll just start from the far end. Dr. Helen Opton, who is the first intensivist at the Austin, female intensivist, sorry. I didn't feel I had to add that in, didn't we? And also you're the medical director of the National Organ and Tissue Organisation in Australia. Next to her is Professor Neil Orford. He is a clinical director at Geelong Hospital and probably better known to many of you as the founder of the Crit IQ website. Dr. Schoenberg Orgard, Dr. Lucy Modra, and soon to be Dr. Kimberly Haynes, a critical care physiotherapist who is currently completing a PhD into quality of life in critical care survivors. Dr. Diane Chamberlain, who you met this morning, she is the current president of the ACCCN. She's also a lecturer at Flinders University and has many years' experience in both critical care and retrieval nursing. And Dr. Young. Okay. Let me start with the question then. I'll actually start, if it's all right, with this afternoon we talked a lot about critical care medicine and the doctor side of things. But it's all right, I'm going to start by asking Diane and Kimberly, I think it's fair to say there are a lot more female representations at the clinical level at female physios and female nurses. How does that pan out, though, into sort of more leadership roles and in academic areas? Would you say that ratio is consistent? A lot more women in those areas, or?
It always fascinates me when we get an enormous amount of, a large amount of proportion of females into a nursing program, for example. And then into the critical care program we would get the proportions change a bit so that there's more guys that come into with the nurses. And then you go into the ICU, for example, or even any clinical area. And it seems to me that the proportions of people that get accepted into the management positions in terms of males is then skewed quite considerably towards the male gender. Not just that, but what I also find is that the women that are in the management positions are often the ones who haven't had any family or have any caring responsibilities outside their work situation. So it's an interesting sociological study. Would you like me to continue?
Yeah.
I have my hypothesis on this. It's interesting, I think, that women actually have this gender schema where they see the man in the management role as a natural progression, and in fact they don't put women into positions because they don't see it as a natural progression. And I think that they're the worst enemy, in a sense, for promotion. Anyway.
Yes, certainly I think within allied health and certainly within physiotherapy at an undergraduate level, it's probably about a 50-50 split, but then it splits out into males tending to go into private practice and sports physio, and then women are drawn into the public health sector. So my experience has been that there's not so much of a gender imbalance within allied health, and most of our senior roles are in fact held by females, but I think that's more a case of just by nature, not necessarily by design, a little bit just the way it is. But yeah, that would be my
that's more reassuring.
Yeah, experience.
Neil was a director of an intensive care unit. I understand.
You were going to say token male.
No, honestly, I've been trying to bite my tongue not to say that or comment on the males in the audience. However,
I know how Julie Bishop felt in the previous government.
You employ women, both as intensivists and I presume as trainees as well. What do you think, what are the benefits employing women bring and what are the challenges to either keeping them there?
So for those of you who don't know, we have 8 full-time intensivists. When I started 15 years ago, I was the 4th and we were all male. The 3 of the last 5 appointments are female, so I've now got 3 female colleagues. I asked them these questions because I figured it would be, it's not really my view that matters here. So their response surprised me a bit because I thought, although there's no active sort of misogyny in the workplace that I'm aware of, that we see, I see that sort of soft misogyny, you know, in terms of biases and, you know, when I walked down the corridor, they said to me once, where I was walking down the corridor, 2 of them, and they were telling me how there was this sort of passive misogyny that went on in the workplace, and I said, you guys don't know what you're talking about. And I know, I was trying to get them wound up, but they're quite scary and intimidating, so I don't know why I did. And we came across a group of male physicians walking towards us, and they all said hello to me and ignored them. And I was just appalled. I presumed it's because they didn't like them either. But, so I asked them about employment, and what really surprised me is that they said that one of the reasons they work at Bowen Health and work in RICU is that it's a very supportive environment. We have in the last 4 years employed a corporate sort of leadership coach who's worked with us extensively, so we've all been psychologically profiled, team building. And what they tell me is that that's led to and promoted behaviours just in general about respect and trust with each other, separate to gender. But their feeling is that because we've adopted a very transparent and open and sort of respectful communication with each other, and it has been quite painful to do, I have to say, for all of us. That
not the respectful communication.
Being exposed to your colleagues, and that a lot of those issues came out. Now, some of them I think were gender-based, some weren't, but I guess that's helped. In terms of retaining them, they're fantastic colleagues. I would hate to lose them. One has just come back from maternity leave with 2 children. I don't. I did what I think you're supposed to do, which is support and encourage her, and I think she's got another 30 years, I hope, of working at Bowen Health. So I can't believe I'd even address the issue of maternity leave being an issue, but I suppose it might be in some places. But
yeah, well, I work in intensive care. I was a 3rd female intensivist employed, and there are 5 of us. And I must admit, it never entered my mind that gender was an issue. So Helen, I'm going to, as an issue,
5 female intensive care specialists at the hospital at
Yeah. And actually, we've only as one of our male intensivists is on sabbatical at the moment. There are only 5 men, so we're and we are clinical head. Our clinical is a female as well.
So look, I think the main issues have been outlined. I think this unconscious bias, I came across the term homosocial reproduction, which I really loved, which is where people who are in positions of appointing people and giving people opportunities to step up and take leadership roles tend to subconsciously appoint people who are most similar to themselves, because that's the typical leader. They tend to be men. So there's this reproduction of people who have the current characteristics of leaders, and I think this unconscious bias, this perpetuation, and it's mostly by men because they're in the leadership positions, but also, I'm aware myself at times having the same sorts of personal insights that Michelle shared. I think the second thing is one of confidence. I think women are generally less confident. They don't put themselves forward. And I think the third thing is parental responsibility. and the fact that men who have wives at home have a huge advantage. Part of my ability to, I think, progress in intensive care and succeed is because I also have a wife. I have a full-time male partner who doesn't work. I think it's a hard environment for many professionals to, succeed without that support, and it's not in our social norm for women to have full-time male partners at home with that role reversal. I'm really interested in this issue of how we deal with this issue and the risks of, this merit issue and, the quotas. And I think those of us who are broad-minded and seek inequality will take the trouble to understand all of this, and if women are selected because of their gender for opportunities at conferences or other leadership roles, that will be well and good. But those in our sector who aren't interested in this, and let's face it, many men, if women are appointed for gender reasons, it will potentially work against us, and I think there's a risk, and I'm not sure what some of the solutions are.
On leadership, women's leadership positions in our profession, I know it was interesting that the college in ASM board, I've been on the ASM board for 6 years, so what are the barriers to getting women in Australia into those leadership positions? Why aren't people, because they're elected positions, they're not self-selected. I noticed that Jack tweeted a while ago that in SCCN it's 8 or 10, I think.
So we actually recounted it. It looks like including the exception of London and 11 women in 10 in the US.
So in the US. So I don't know what's the barrier, do you think, to women putting themselves up to those leadership roles to then encourage other people to follow suit?
Look, I think when people are early in their traineeships and university, often things are more objective. There's expressions of interest, job applications. I think for seniorship leadership roles, it's more often a tap on the shoulder. It's senior people actually providing opportunities for those coming up through the ranks and encouraging them and supporting them. We've heard about a couple of hospitals around, the town that I live in, Melbourne, that have got particularly supportive environments for women. I think, work in one of them. It's not the case everywhere. I think we need to deliberately, it's not just for women, it's for any trainee, but women particularly, because there is that lower level of confidence, though not competence. So I think, if you had the ANZIC's board and there was a deliberate seeking of women to be on the board, and members were asked, are you aware of some women who you think would be interested and contribute to the board? Seek them out and invite them. They will be reticent in putting themselves forward because they won't feel it's part of the club that they're welcome to join.
Can I ask a different question? So I think there was a certain genius from the organisers for putting this in a panel with a lead patient safety talk. And I think there are lots of reasons why actually the gender skew is a patient safety issue that limits the confidence for our hospitals. But I'd love to hear you guys articulate some of the reasons why the levels of gender imbalance are actually a patient safety issue.
So I can make a comment. There was an interesting publication in the MJ recently where they looked at male and female trainees, and men are often very confident. They will put themselves forward. Women are often more cautious. So it comes putting your hand up and saying, yes, I'm ready to do that operation as a trainee surgeon, or I'm ready to put these lines in. Women are actually just as competent, but they're more cautious. They're more concerned about risk, and I think those characteristics of women may well feed into what you're talking about, taking a more patient-centred, cautious approach with safety rather than having a go and I'm not expressing that particularly well, but I think those characteristics are probably generalisable differences.
There is an opposite way of expressing this, which is one of the goals of us having team training and trying to work better as a team is a bit of it's about communication with external teams and internally, and is removing the sort of non-team player antagonistic alpha male personality. And I wonder if, and because that's now become a very big part of how we work together, and I think how we'll recruit in the future, if I could, I would profile everyone who we interview. I wonder if that will push some men out of our unit more so, if it's true that those personality types are more male, which I think it probably is. So I wonder if we'll just, and that will produce a safer environment. So I wonder if that we're naturally could head that way. But
I wonder another reason of safety is also to do the link is the female communication style. Female doctors are much more likely when they're having conversations with families to be more patient and family focused, have a much more open discussion, and that's sort of evidence-based. And if I think of what our insurers are always telling us about when there is a problem and how you deal with it, if you can discuss it and debrief both with the people it's happened to and in the team, you're going to gain more out of that and prevent the complaints and also, I guess, prevent the errors. So I wonder if having a female communication or the style in which women communicate lends itself to improving safety to a degree.
If I can just add to that, I think part of it links back to that idea of broadening our stereotype of what an intensivist is or should look like. And in fact, there are probably, I think our profession would benefit from more diversity in what intensivists look like, how they behave and how they communicate. And I think there's an increasing amount of evidence, certainly in the business world, that having diversity on boards, within senior leadership positions in organisations, actually has improves outcomes, which I suppose in the business world is all about money. But I can see a direct correlation to that in healthcare, that bringing diversity, be it gender, ethnicity, religion, into your workplace could improve safety.
Oh, sorry, yes.
Thank you. I see a link too between the way that women perceive their practice and what they see as important, in contrast to male counterparts, in the sense that this then links to what they see as important in research and what research they want to pursue. But then again, we find that the glass ceiling gets hit with female intensivist and nursing research, is that often the people that decide whether it's quality research to be funded is then looked at from a masculine perspective. And so the funding is often a lot less for female-led research. I've got a sore neck from that one.
Playing this life on the easy setting. I'm a white, male, firstborn in a rich country. Doesn't get better than that. And I travel around in the little garden of our intensive care anaesthesia department, and I'm sure that occasionally I squash the clouds just because I wasn't. That's far from my intention. And rather than necessarily relying on the females whom I get in the way of leaning in and saying, it wasn't the right thing to say. Is it that how might I lean out or reach out in that circumstance? What little things can I use to check myself before I go through another time of China shop? And my comment is that the men in the audience are asking questions at twice the rate.
We appreciate your questions nonetheless. I think that part of this, for me, talking to people about this issue has just been so enlightening, because I think people are very enthusiastic about these issues and the opportunity to overtly talk about them. But I think for many of us, and myself included, it's not something, as Michelle said at the start of her talk, I think a lot of people come to feminism as it is quite late, and they're not things we've really thought about in depth at all. And for me, I think the fact of having this on the agenda and thinking about it or doing the bias self-test and realising this is something that affects me and it probably affects everyone I work with is such an important step. I would say that's the most important step. That now even the fact that you're aware of that, I expect would probably affect your behaviour.
Could I just make one comment about men leaning in as well? As much as communicating and talking about the issues are important, I guess that in the other side of communication is the listening. Listening to what people are saying, listening to how they are expressing themselves, and listening to the underlying commentary that is going on. And we have to practice listening for most of our time.
I just had more of a comment than a question, and I work in an academic intensive care environment, so I have additional penalties against me because I'm actually not a doctor or a male. So I guess one of the things that I've learned that has been incredibly helpful has been to have very strong female mentors and to use a formal mentoring program. And I just wondered if you, particularly Nancy, an opportunity to consider a formal female mentoring system. It's incredibly successful. It's used by Monash University. The Clinical Trials Group has recently started a mentor program which I'm involved with. I've been on both sides, both mentor and mentee, and I've found it very, very helpful with strategies and sometimes just a good whinge when I have felt partly done by.
Yeah. Can I just comment? So I was speaking yesterday with our Executive Director of Nursing and Allied Health, and she certainly feels a sense of responsibility and obligation to provide that mentorship for people within the organisation. So whilst there may be formal and there may be informal structures, but I completely agree linking in with these people or females who are in positions of leadership and learning from their experiences, but also as well, what within your organisation or local areas, what existing structures are there that you can tap into. So at our organisation we have a diversity committee. So again, putting this on the agenda and using, your infrastructure locally, I think, to help advance things as well. Agree.
Yeah, from the point of view of the Women in Intensive Care Medicine Network, this is something we're very keen to set up. And one of the things that we have come across with it is that in Melbourne, where we've started, there's a relatively small pool of female intensivists upon which we'd be drawing to provide this mentorship. And they're the same female intensivists who we'd also love to speak at our meetings and speak here. Helen's been kind enough to speak at a dinner 2 weeks ago and now again this week. And so I think that led to the very obvious question, well, why can't we have male leaders mentoring women? And I think that's a very valid option. And there's clearly a lot of men who are very engaged in this issue who I think could actively help in that way, just as well as their female senior colleagues.
I might take some questions from here rather than just the hands up. Do you think there's a tendency for female intensivists or female intensive care trainees to try and imitate their male colleagues' attributes? We certainly
hope not.
Michelle may have more to say. I mean, I think in any area you want to fit in. You want to fit in. You don't want to make your personal physical characteristics make you seem separate to the cohort of people that you're needing to fit in with. I think that's a general human requirement to fit in, be accepted, and then advance in a particular area. And certainly when I'm at work, I don't talk a lot about child rearing issues, maybe more with my male colleagues who have young children, but I don't highlight the issues that I might be facing as a woman with male colleagues. I dress pretty, I don't know if the comment was about what we're wearing, but I try to not highlight my female difference, and I think that's...
Yeah, I think I think I realised quite early on that you can be odd, but you have to be a lot better if you're going to be odd, with any parameter, be that gender or any other personality trait.
Have any of you done a psychological profile that's male or female?
So that's interesting when you say about trying to be. So because we've all been profiled, I'm on my own psychologically in our group, and the others don't. So if you're going to be odd, you want to be the director.
That's right.
And they don't. We recognise that we've all got different strengths and weaknesses, and so no, I don't think anyone's trying to be at all anyone else. They're trying to be, and I guess because we've been fairly overt about it, we recognise that there are, each one has differences, and so I don't think any of my colleagues would, female or male.
Yeah, but it sounds like you're in a work environment which is actively promoting diversity, or actively acknowledging diversity.
Individuality.
Yeah.
I mean, in the interest of teamwork, and saying we'll try and work out your strengths and weaknesses and work to them.
Yeah.
I mean, I wonder whether defining goals that are patient-centred, family-centred, unit-centred, team-centred helps define the steps you need to take to get there. That if you say, I want an empathic workforce that listens and communicates in a diverse range of styles, haven't you just defined a goal that you can collectively work towards? And then one of the strategies is about balance. I think that's a way of articulating where you want to be. And yes, the steps are obvious that we want to get there with an improved gender balance. But I think it's defining the qualities. Do you want an ENTJ or an INT, whatever the other Myers-Briggs is on your team? And profiling is just one step of getting that way.
Just wanted further on the psychological profiling is that we did some work with intensive care nurse senior staff and found that they had more masculine profiling than the rest of the group, which is why it sort of fits into the role that they learn to be able to fit in.
Hi, Lizzie Skinner from Western Health. Thanks guys for the network and for raising some of these issues. Like, it's obviously incredibly important. I had a question though about how we define this moving forward, because some of these things can be related to gender. We've heard that everyone has these unconscious biases, but there's also a lot of other biases that relate to other things. Some people just don't like each other. I've seen women treat other women poorly with relation to, ceilings. So I'm interested from the panel, how can we ascertain these differences? How are we going to tease out what relates to the gender biases versus these other issues?
Research it, I think. So putting it on the agenda first and talking about it, and then maybe some research.
How are we going to define that? That's my point.
Sure. It's not. It's not so. I don't think it's particularly straightforward to get that definition, but I think it's at the end of the day, what do we want it to look like? How should it look like? What is our community in intensive care, and how does that represent the broader community? So I think having a look around the room and seeing who we are and what we represent, and ultimately where do we want it to shift towards. But talking about it first, I think, is the first step.
I actually think the gentleman in the front here, identifying the goal of what you want this to look like. It's a human-centred profession. Let's not reinvent each time what we're doing. It is about the goal at the end of the day is for the patient and for the family and human-centred, and we can work around that. And if that shifts the paradigm from the individual to the people we are working with and for, and I think that's a really important aspect.
Okay.
They say that you're not selected
Yeah, I think you've brought up a very obvious issue. Only women can bear children, and how do we support women both whilst all number of our jobs provide maternity leave contractually, but the other thing is it's very difficult to work as a female intensivist when you're 34 weeks pregnant and be up at 2 or 3 in the morning. And my personal experience was I just seemed to disappear off the on-call roster. I worked in an incredibly supportive environment that allowed those around me helped me do that. But I guess as people who are looking at employing women, that is going to happen, not just them taking the time off, like I say, to have the children, but also working through it. You're physically incapable of doing a number of things. So, how do you think you answer that?
I think, the whole pregnancy and maternity leave is one thing, but I think parental responsibilities are far more longer afterwards. And I think we need to talk about parental flexibility, and we need to encourage workplaces that enable men to participate and fully assume parenting roles, so the natural default isn't the woman. And I'm aware of a young male intensivist who's at a very supportive unit who was very anxious about approaching the director to talk about part-time work over the coming year so he could take more time out to be a parent, so his partner could more fully pursue her professional goals. So, I think it's okay for women to do that, although it may be difficult, but it's much harder for men, and the perception and whether they're serious about their job or not, and I think we need to make it the same.
Yeah, I think Scandinavia is often touted as the leader in this area with good reason. And one of the, I'm sorry I can't remember which Scandinavian country it is, but I know that there is a system, which I think is in Denmark, where there is a essentially paid parental leave for each parent. The primary carer can take the larger amount, be that the normal 12 months or whatever is allowed, and the other carer, who is often the male, can have 3 months of parental leave as well. And the kick is that you can't give your leave to each other. And the effect of that was that it really normalised men taking parental leave for several months, which I think importantly affects the perception of people of both genders in their 20s and 30s as potentially going to have children. I think intensive care is an incredibly competitive job market at the moment, and I know that a lot of women who are contemplating how are they going to have children at the time that they're also competing for jobs. And I think if you can create a perception amongst employers that men are just as likely to take several months leave in order to take on their family responsibilities, this will make a meaningful impact on the gender balance, and certainly that is reflected in the gender balance in the workforce in those countries.
We've got time for about one more question before afternoon tea.
Sorry, I was just talking to except for the initial applications not having gender as part of the shortlist.
Yeah, I think the National Australia Bank, which is one of the big 4 banks in Australia, has just started that initiative, which I completely agree with you. I think it's fantastic. There's one obvious problem with it though, which is that women who have taken time out for parental leave will have unexplained gaps in their CV, or gaps that, if they're declared as parental leave, will probably declare them to be women. So I think it's the way forward. I'm not sure how to address that second problem I mentioned though. Yeah.
Carl? Yeah, well, I guess maybe we shouldn't look at them as gaps in our CV with actually relevant time. Someone spent 6 months travelling, someone's did something else completely different. Actually, that's really relevant information. It shouldn't just be about where you've worked or what you've published.
So they're all good places to work, and there are units in Melbourne, around the country, that have very low rates of numbers of female intensivists dropping. And mentors for female intensivists won't change the behaviours of those institutions. So, or maybe, I don't know if it's the unit or the hospital or whatever. What do you do about that? Or do you have to wait for everyone to retire?
Yes.
But do you think they'll just keep hiring men?
I guess I wonder if this is something that, we need to identify what specific values are, what qualities and values to an individual unit or hospital women, employees in varying roles bring, and when you've got that evident, it can be part of the justification of actually why it works.
I'd also hope that units that are having such high turnovers or suffering from burnout in their intensive staff, that's not going to be good for their unit in the long term. And I mean, there is a huge cost to the unit in terms of the team, and then a financial cost in replacing those intensivists. So you would hope that the way forward would be a model of a more sustainable workforce. Yeah.
Well, thank you everyone for attending and for our panellists and speakers. I've not yet identified where the speakers hall is, but hopefully I can we can find our way there, so that if people have further questions to ask you, they can do that. And can I also just say the interactive zone this afternoon is Philips, and they're demonstrating latest patient monitoring technology. So if you would like to attend that, that'd be great. Thank you.